Well, hello, everybody. Thank you for joining us today for our discussion on COVID-19 vaccine hesitancy, brought to you by Science is Us, a program of the American Association for the Advancement of Science, the Chronic Care Collaborative, the Colorado Vaccine Equity Task Force, and Healthier Colorado. My name's Jake Williams. I'm your host, Executive Director of Healthier Colorado. A tiny bit about us. We are dedicated to improving public policy for the sake of the public's health. These days, we've been pitching in our efforts along with community partners to make sure that we get shots in arms as quickly as possible, especially with an equity focus. And so we're very much invested in this discussion today. We're fortunate to have a distinguished panel of experts. I'm going to introduce them to you momentarily. First, just wanted to run you through a few slides about Zoom etiquette. We're probably all familiar with it, but just in case, you'll see some notes here. This is being recorded. You can always raise your hand. You're in listen only mode right now. Please mute your line when you're not speaking. And if you lose your connection, try to just close and come back in. And then we are going to take questions as well. You can use the chat function that can be accessed at the bottom of your screen. We'll probably take most of those at the end. We'll just see how we flow along here, but please don't hesitate to ask questions. All right. Before we begin our discussion, I would like to introduce Tatiana Neen, Program Director for Science is Us, who is joining us from Washington, D.C. Tatiana, welcome. Will you please give the audience an overview of Science is Us?
Thank you, Jake. Good afternoon. On behalf of Science is Us, I want to start by thanking our co-sponsors, today's panelists, and everyone who is taking the time to join us today and learn more about vaccine hesitancy and how evidence-based policy can help decision makers in Colorado and the rest of the country address this issue as we continue to endure this pandemic. Science is Us is a grant-funded initiative housed under AAAS, the American Association for the Advancement of Science, and supported by 9 other national scientific organizations, including the American Chemical Society, the Federation of American Societies for Experimental Biology, and the Consortium of Social Science Associations. These 10 organizations form our steering committee. We emerged from the growing systemic gap between policymaking and science and engineering. Over recent times, science and engineering has not been taken as a paramount for success of the country. As a result, the US is facing several challenges around R&D competitiveness, STEM education infrastructure, workforce development, etc. These issues are of extreme relevance given that our research shows that STEM powers about 69% of the US GDP, creates jobs for Americans of all backgrounds and education levels. So the mission of Science is Us is to build, mobilize, and guide communities that challenge policymakers with local and national importance of acting in support of science and engineering. The way we do that is by developing multi-sectoral partnerships with local community leaders, business, and policymakers in various states and co-create targeted narratives that highlight the importance of science and engineering and how it impacts and benefits all of us. Ultimately, we aim to tell a broader and more inclusive story about the STEM community and break the existing silos to have every person, policymaker, or organization become champions for science and engineering, given that our future depends on it. We want to invite you to visit our website, scienceisus.org, follow us on social media, and stay informed to get involved with our activities and resources. I'll be sure we include the links in the follow-up email after this webinar. Thank you for your time, and we hope you enjoy the information today. Back to you, Jake.
Thank you, Tatiana. It is now my pleasure to introduce our first speaker, Dr. Raymond Goodrich. He is the Director of Infectious Disease Research, the Infectious Disease Research Center at Colorado State University. Ray served as Vice President of Scientific and Clinical Affairs and Chief Scientific Officer for Blood Bank Technologies at Terumo BCT, a leading global medical device manufacturer. He has worked in medical research for over 29 years and managed research staff and development programs in the fields of transfusion and transplantation medicine and pathogen reduction technologies. He's been awarded over 50 patents. It's becoming clear from this that he's a much more accomplished person than I am. I just wanted to interject. And has co-authored over 200 peer-reviewed articles and abstracts. He has also served as principal investigator for the United States Department of Defense grants for the development of a transportable blood treatment system. Ray, thank you for taking the time.
It's my pleasure. And I will say I had a lot of help along the way, so certainly not an individual effort. Did you want me to just go into slides at this point? I have some slides that could address some basics behind the...
Yeah, I think the scientific community succeeded in developing COVID-19 vaccines on a rapid timeline. At a high level, if you will, could you explain the science behind vaccine development and help us understand how we've been able to develop and safely deploy these vaccines?
Certainly. It really has been an amazing story. Let me know if you could see the slides coming up there. Okay, excellent. So very early on in the pandemic, one of the questions that I was often asked is, how long is it going to take to develop a vaccine? And back in the February-March timeframe of last year, I put this slide together kind of describing an experience with vaccine development that a lot of people are familiar with, the Salk vaccine for polio. And if we looked at that as an example, it started with an award to look at the polio virus and develop a vaccine in 1948. And it ended with all of the studies that were required to be done to prove that it was safe and effective, taking 7 years, in essence, until the vaccine was announced to be safe and effective. And I think that it's quite a testament to the science and the scientists and others who have been involved in developing these new vaccines that we've been able, through technology and through the knowledge that we've gained over the years, through the investment in science and medicine over the years, to really compress that time frame down into something more like 7 to 8 months. So it really is quite remarkable to think about it in terms of the benefit that advancing science in these areas has had relative to our ability to respond to something like the SARS-CoV-2 pandemic that we've been dealing with for the past year. All of vaccines basically work on the basis of having some unique aspect of the virus that you can utilize as a point of vulnerability in creating immune responses that prevent the virus from infecting cells and causing disease in people who are exposed to the virus. That Achilles heel, so to speak, in the SARS-CoV-2 virus is a protein called the spike protein, or sometimes referred to as the S protein. And it represents the spike. If you look at an electron micrograph of what the virus looks like, it looks like a sphere with these spikes sticking out from it. Those proteins actually represent sort of the key that is used to unlock the cell and allow the virus to enter and infect the cell. The lock, so to speak, in this case within the cell, is a protein called angiotensin converting enzyme 2, or ACE2. So this is a protein that's present in the surface of many different types of cells. When the spike protein from the virus binds to that and enters the cell, that's how infection occurs. And the fact that this ACE protein is present in many different types of cells, in lung cells, in GI tract cells, that's part of the reason why the effects of the SARS-CoV-2 virus are so broad and diverse. Depends upon which tissues or organs are infected, the types of adverse effects that we see in patients. But the idea is that if we can find a way to block or alter that spike protein in a way that prevents it from fitting into the lock, we could essentially prevent the virus from causing infection and hence subsequently causing disease in patients. Get this in the right direction here. Now, how do we do that? Well, there are a variety of ways. There are a lot of different methods that people use in order to create vaccines. Many of them have been around for a long time. The Salk vaccine is an example, 40, 50 years or more. But there are also some new methods, some new approaches that have been used. One of those approaches is using DNA or RNA as the method to deliver a signal to the cell that causes the cell to produce the spike protein. The RNA or DNA by itself can't cause disease, but it can cause your cells to produce that spike protein and express it in a way that your immune system can react and produce antibodies or cellular immune responses, your B cells and T cells that recognize that foreign protein so that when you're exposed to the virus again, you're protected because those antibodies or those cellular immune mechanisms will interfere with the binding of that spike protein to the cells and prevent infection from occurring. There are viral vector-based vaccines, which use a different virus to deliver the signal or deliver that DNA or RNA to the host cell to allow that immunization effect to occur. And then there are inactivated viruses. The Salk vaccine is an example where you have chemical agents that are used to produce an inactivated virus that can't cause infection, but has all of the proteins there that the body can recognize as foreign and generate immune responses against. So all of these work by virtue of creating immune responses that allow the body to see these agents as foreign, to generate immune responses that then protect you when you're exposed to a live virus. There are other forms as are described here, but these are three in particular that I'll go into a little bit more detail because these three are methods that people have used in generating vaccines for SARS-CoV-2 to prevent COVID-19 disease. I actually borrowed a couple of sheets from the Immunize Colorado website. It really is an excellent place to go for information that describes a little bit about how these vaccines work. And as I just described, you have the viral vector vaccine, the adenovirus vector vaccine from Johnson & Johnson. And again, how that works is the virus itself is kind of hollowed out and the genetic material, the DNA, is replaced with DNA that codes for protein, the spike protein that's associated with the SARS-CoV-2 virus. When that virus enters into cells, it basically has the cellular machinery manufacture that spike protein. And when that spike protein is expressed, the body can recognize that as being foreign and can mount an immune response against it, which then subsequently protects you from infection. The messenger RNA vaccines Johnson or Pfizer and Moderna have developed follow a very similar pattern in that they use messenger RNA, which again codes for the spike protein. And these are contained in small vesicles that are taken up by cells. And then that RNA signal gets processed into the spike protein, which can express itself on the surface of those cells and then present that to the immune system to help mount that immune response. There are also methods, and this is one that my group here at Colorado State and many of my colleagues at Colorado State have been collaborating and working on with support from the NIH and BARDA, has been to utilize an inactivated vaccine for SARS-CoV-2. So that's where we take the whole virus, not just the spike protein, but the whole virus, and we treat it with a method, and we're using a photochemical method that's very selective, that destroys the nucleic acid, but preserves that protein coat and the spike proteins that are present on the surface of the virus. So when it's inactivated, it can't cause infection, but it can present itself to the immune system much like a whole intact virus particle that was alive would do. And your body again generates an immune response to recognize that in the future to protect you in cases where you may be exposed to live virus in the future. I described this somewhat as imagine that you could scramble the yolk of an egg without breaking the shell. It still looks like an egg. You don't realize that it's been altered until you crack it open. And that's what we're doing with the nucleic acid signal that's inside that virus capsid by using this photochemical method to generate a vaccine candidate. And here at Colorado State University, we've studied this rather extensively. This is an article that just published a few weeks ago, looking at the ability with many of my colleagues here on faculty and staff and some of the students working on this program. We've been able to show in animal models in preclinical testing that you can get very effective immune response to the vaccine, that it's protective when those animals are exposed to the live virus, and that it preserves lung tissue integrity even at substantial periods post-vaccination when exposed to the virus. So again, these are all methods and they all have the same basic principle in mind, that is to present the proteins from the virus in a way that the body can recognize them as being foreign and generate an antibody or a cell-mediated immune response that then subsequently protects you when you're exposed to the disease in the form of a live virus. Why is it important that we continue to work on vaccines? You know, you might say we have 2, 3, 4 of these vaccines now that are becoming available or are available. Why is it important that we continue to work on new methods to address this disease? Well, this disease in particular is very pernicious in that it can change. It has an ability to mutate and to change. And as we go after that spike protein, for example, one of the things that can happen within this virus is that spike protein can change. It can be altered. So as mutations occur within the virus, that spike protein changes. And if we are generating an immune response against that spike protein, if the change becomes significant enough, the antibodies may no longer recognize the binding sites that are present on that spike protein. So it could still have a way to enter into the cell and cause infection. Many of the variants that you're hearing about in the literature are due to the emergence of these mutated versions of the virus that have altered spike proteins. In many cases, the vaccines that are available today, the Pfizer and the Moderna vaccines, have been shown to be effective against them, but the concern is that a mutant or a variant may arise which shows reduced effectiveness of the vaccines in protecting. And so having multiple mechanisms and multiple approaches to be able to create vaccine candidates is going to continue, I believe, to be a very important thing for us moving forward. And why is that important? It's because we're not out of the woods yet. We need to have people continue to be vaccinated in order to achieve what you may have heard of as herd immunity. And that's basically when you reach a certain point at which enough people in the community have been vaccinated that the likelihood of being exposed to the live virus and being able to transmit the virus goes down. There was an article just recently, I think, talking about Larimer County predicting that it may be able to reach herd immunity by end of May of this year. So it's moved pretty rapidly thanks to increased vaccination. When you take into account people who've already been exposed to the disease, we can have models that predict at what point herd immunity might be attained. And that's driven in large part by people being vaccinated and continuing to be vaccinated so that we reduce the likelihood of exposure occurring within the community. So hopefully by sometime later this summer, certainly early fall, we should reach a point at which we've achieved herd immunity. But as stated here, I think a very important point that I've heard people mention is that this is a local and not a national concept. And what that means is that if people within your community, your immediate community, are not vaccinated, the potential for exposure exists even if on a state level or on a national level, most people have already attained that herd immunity level. So it's very important, even at the local level, that we continue to promote programs and make available vaccines on a broad and equitable basis to our communities throughout the state and around the country. And that's sort of the background that I had, Jake, just describing a little bit about where these vaccines have come from and where they are today.
Just had a quick couple follow-up questions here. I've been fortunate to be vaccinated now for a while. How long can I reliably expect to be immune?
Well, because our experience with these vaccines is relatively new, that's still a question that we're answering. And today, the data suggests from things like the Pfizer and the Moderna vaccines that you at least have protection for at least 6 months. And I would emphasize that it's most likely going to be much longer than that. But that's where we have data today, indicating that individuals who have been vaccinated are maintaining antibody levels and response levels for at least 6 months post-vaccination. And again, it's probably going to be much longer than that. Protection against exposure to the disease.
And has there been any evidence of variance in that length of time between the types of vaccines?
There are studies that are ongoing today, and yes, variants are cropping up in different parts of the world. Many of the variants the vaccines have been tested against for their effectiveness and have been shown to be effective against. There are a few where that effectiveness is reduced. But there is work that's ongoing to devise new vaccine formulations that will specifically address in the form of a booster the new variants that may be occurring at increasing levels in human populations.
Another thing I've heard is a lot of young people have raised some specific concerns about COVID vaccines impacting fertility. Could you explain the source of those concerns, and are they warranted?
Well, it's a very complex story, as you may imagine. There were some initial reports and some requests that went to the European Medicines Agency when the mRNA vaccines were being approved, of concerns over the fact that some of the sequences, that RNA sequence, coded for proteins, and the sequences were very similar to a protein that exists in humans called syncytin-1, which is a protein that's present in placenta. And a couple of individuals raised a concern that if we're vaccinating people in a way that we recognize that spike protein as being foreign, could that generate recognition that the this protein in the placenta would also be recognized, and you would immunize against it and hence cause infertility to occur? The best analogy that I've heard is, yes, there are some comparable sequences, but that would be like saying that because your phone number contains a 7, I'm likely to be able to call you up just by knowing that. So even though some of the sequence exists, there are many other portions of that sequence that are very different. Also, I think importantly, if we were to observe that there was an effect on fertility, we would see that in people who were infected with the virus just through natural infection. That has not been observed. Because again, if your body is generating antibodies against the spike protein that also recognize this placental protein, we would have seen infertility. That hasn't been observed. There were many people who participated in the clinical trial, many women. Now, in the clinical trials, you had to take a pregnancy test, but there were individuals in both the placebo group and in the treatment group, those who received the vaccine, where pregnancy did occur. And the frequencies were very comparable, and the outcomes have been monitored as people have progressed. So is the concern warranted? In my opinion, no. But I think oftentimes, and Dr. Reich may be able to talk a little bit more about this, how we perceive that data and how we perceive that information and how that manifests into people's unwillingness or their interpretation of that data and subsequent unwillingness to take the vaccine. Oftentimes that's hard to predict. So I think definitely in this case, not warranted, but that was sort of the origin story of how this came about to be an issue that I myself have heard people saying, raising this concern about those vaccines.
Thank you, Dr. Goodrich. We're going to come back to you because I'm sure there are questions we're going to have from the audience at the end. We're going to switch gears here from kind of a clinical perspective to more of a sociological perspective by speaking to Dr. Reich. Dr. Jennifer Reich is a professor of sociology at the University of Colorado at Denver. Her research examines how individuals and families weigh information and strategize their interactions with the state and service providers in the context of public policy, especially as they relate to healthcare and welfare. She has authored and edited several award-winning books, including Calling the Shots: Why Parents Reject Vaccines. Her work has been featured in the New York Times, the Washington Post, NPR, Newsweek, and on the Netflix show Bill Nye Saves the World. Jennifer, just like our last speaker, I hope that I get smarter via digital osmosis from your presence. Thank you for being with us.
Thanks for having me. And let me just start that long period where I offer to share slides and take a minute to bring them up. And I'm happy to be with you all today. I thought I would build on what Dr. Goodrich is pointing to in terms of thinking about what this looks like on the ground as we distribute vaccines. And as I was putting this together, it occurred to me that in COVID time is really different than other time. And so it's hard to remember that we've only had vaccines that have been authorized under an emergency use authorization since December. So we really have only been talking about vaccines and having vaccines against COVID for less than a year since we've even known about the virus. And really, we've only had them in distribution for about 4 months. And that's, I think, worth keeping in mind because we've moved at surprisingly quick speed. And so because it's only been 4 months, but it also feels like a lifetime, I thought I would take us back to Operation Warp Speed. As a reminder, this was a federal program to create a large infusion of money to make it possible for companies to develop vaccines and to test them quickly. And what I wanted to point out today in starting our conversation is not so much the science, which you've heard about today, but really thinking about the beginnings of the process of distribution and where that takes us around equity. So looking at this chart that was created by Operation Warp Speed, what you see is that there was recognition that from the time the vaccines were available, they would be loaded on airplanes through contracts with FedEx and UPS, and that they would need to get to hospitals, patients, pharmacies, long-term care facilities, doctors' offices, Indian Health Services. And this is a list of groups that would need vaccines. And there was actually no real plan for how to move vaccines, how to distribute them, and how to get them from the airport to actual people. And that has been really the beginning of our story of vaccine distribution, is that gap right there on how this was going to happen and what systems were going to be necessary to make that happen has really been, I think, the greatest source of quick innovation at the ground level, at the state level, at the county level, at the local level. And it's been intrinsically imperfect, but we can learn a lot from how it's gone. So in thinking about, what happened in terms of allocation, what we know is that the initial allocation rollout was really heavily leaning on existing institutions, large corporate pharmacies, large healthcare institutions, hospital systems. And so unsurprisingly, the vaccine distribution worked best for the same people that systems and institutions already work best. People who have private health insurance, healthcare workers who are employed by large organizations, people who live in urban areas that have access to pharmacies, which tend to not be well distributed across rural communities. So those who already have best access to institutions had the vaccine quickly. And this is really important to think about because there's been several things that have played a part in this story. So one is that over time, we can see that enthusiasm about a vaccine against COVID has waxed and waned. And it's important to note that the data from July of 2020 were during the rollout of Operation Warp Speed, but there were no vaccines. So these questions were really about a hypothetical vaccine that would be given out for free. Would you take it? And what you see in July 2020 and through that summer was generally enthusiasm for the idea of a vaccine. And that enthusiasm begins to wane, and then it declines rapidly when we get to fall 2020. And that's the point at which the distribution and the vaccine itself become tied to presidential politics. And the more the vaccine science became politicized, the less interested Americans were in getting it. And the bottom chart, if it's helpful, can break that down across political parties. And what you see is the largest decline. So both the people who were the most enthusiastic to begin and those who were the least enthusiastic when it became politicized, you can see that line with the greatest drop amongst Democrats and people who identify as Democrat. And then you see a rebound as we get through the fall, as we begin to move through emergency authorization, as clinical trial data become available. And that what we see now is that there's generally enthusiasm as we moved into January. And as a reminder, the 2 mRNA vaccines were authorized in December. The Johnson & Johnson vaccine was authorized in February. So at the current pace of vaccines, the estimates, and these are changing daily, but the estimates as of last night were that by June or July, we could expect to approach a point at which 70, 80% of the population will have gotten a vaccine. And I'll say that while I was on the signing on to this webinar, I saw the press release today that Pfizer has just requested emergency authorization for 12 to 15-year-olds, which just happened momentarily ago. And so that's going to actually change our trend line, because there is this point where a significant portion of the population are young people, and that's going to change our ability to get to herd immunity. What you can see is that nationally, as of yesterday, at least 34% of the US population has received one vaccine, and the one vaccine and the fully vaccinated number include the Johnson & Johnson in both piles. Obviously for mRNA, it's 2 vaccine series. And that Colorado is doing a little better than the national average. We are slightly ahead, and we are using a slightly higher percentage of our vaccines. What's important, though, in going back to the original story about how is it that these institutions that serve certain people best rolled out vaccines best to those people, is that matters in a bunch of ways. And one is that what we know about vaccines in general, and this is from research on childhood vaccines, is that one of the greatest predictors of who doesn't want a vaccine is the number of people you know who also don't want a vaccine. So we know vaccine hesitancy clusters. And part of that clustering is personal experience, that it's not so much like it's anti-science or it's ignorant, whatever, but we all every day look to our family, our friends, our community, our social networks to get information. We look for people who share our values to understand what their decisions are and how those affect our decisions. And so when we look at who got a vaccine first, what's really interesting to note is that as of February, when you look at, do you know, and this is the gray that I circled for you, doesn't know anyone who's been vaccinated against COVID, there's only, in February, 20% of adults didn't know anyone, but when you start to break that down by race and ethnicity, by income and by education level, we start to see large disparities. And so it's somewhat unsurprising that the people who were expressing the greatest hesitancy about the vaccine early on also didn't have any firsthand experience with people who had gotten the vaccine. And as access has improved, we see those numbers shifting, which I'll show you today. So, and then in thinking about where this takes us today, what we see is that this has that as we've moved up, and I think we hit 4 million vaccines in one day this weekend nationwide, we can see that as more and more people are accessing vaccines against COVID or against SARS-CoV-2, then what we see is that the number of people who are uncertain or who are truly hesitant about a vaccine is shifting. Now, you will note that over time, the far right side is that green color is people who say they definitely don't want a vaccine. And those are people, if we were classifying anybody as anti-vaccine, that's the group. And there has not been very much movement over time in that group. But the greatest movement, which to me is the most interesting and the most exciting, is not the people who say, I definitely don't want a vaccine, but the people who say, I want to wait and see. I want to see how it goes. I want to see if it's safe. I want to see what happens with side effects. I want to see people in my community and how it's going before I sign up for it. And it's also not surprising that we saw great hesitancy early on amongst BIPOC communities who have long histories of distrust of unlicensed pharmaceutical products based on community experiences of exploitation and scientific experimentation, and also distrust of medical systems that every day illustrate the ways that they encode for racial disparities and don't take people's experiences seriously. And as vaccines have gotten out in the community, as that number of people who have gotten vaccinated has increased, what we see is the number of people who say they want to wait and see is shrinking. And that's really important because that's the hesitant group who was never totally opposed, but felt cautious about new technologies and new vaccines. And that's exciting to see that movement and where that's going to take us over time. What we know is, having said all of this, that we still have disparities and we still have challenges ahead. Every state in the country has under-vaccinated their share of the Black population, and Colorado is no exception to that story. What we know also is that the personal decisions about how people assess risk and benefit in their own life is tied to their perceptions of the severity of the disease, the opportunities that they may lose or gain based on access to vaccines, and what this means for their personal goals. And we know that the effects of COVID have not been equally distributed. So these are some examples as of February of the racial disparities amongst Black, Latino, Indigenous, Asian, and white communities in terms of who has experienced the highest death rates. And what's not shown on this chart, but is available in other data, are that in addition to having higher rates of death, we see that there is death at younger ages amongst Brown and Black communities. And that's significant for thinking about the experience of COVID and the ways that individuals are going to weigh decisions for themselves and their families. We can break this apart into more fine-grained ways that I think are informative. And what you'll see as of March, and I will confess that I've been a social scientist for a really long time, and I don't usually have to update my data and slides every week. And COVID is one of these moments when you see a 20% change in opinion, something is people are making decisions and weighing information in real time in ways that we don't see on very many other kinds of social experiences. But when we take a look, this is as of March, at the end of March 22nd was the last day of polling on these data. What you see is that there's some really interesting trends about who wants to wait and see and who's opposed to vaccines. And although we've spent a great deal of time talking about hesitancy amongst Brown and Black communities, what's really important to note is that since the very beginning, the greatest source of hesitancy that has been the most unmovable has been around people who self-identify as Republican or Republican leaning, and also amongst white evangelical Christians. That those are the groups that have maintained the greatest opposition to the vaccine, and also the greatest hesitancy for thinking about what this is going to do and how this is going to play out for them. We also know then, as we think about our strategies in Colorado moving forward, that in addition to thinking about those groups, we also have to spend some time thinking about the hesitancy. So it's really the wait and see amongst young people, 18 to 29, which you can see towards the bottom. And in some ways, that's an interesting group. I think the last question that Ray answered about fertility is part of that story. But we also know that the way that COVID risk has been messaged since the very beginning has communicated to young people that they're not at great risk of infection. And that if they become infected, that they're not at the greatest risk of hospitalization or death. And since the vaccines are proven to prevent to a high degree of efficacy, hospitalization, and death, young people don't necessarily see the ways that they need this vaccine, given that we've told them for the last year that they are the lowest priority and they also need it the least. And that's going to be a conversation, I can say as a university professor who works with undergraduates, but I think for all of us, we're going to have to continue to grapple with what that means and how we communicate risks and benefits, both to the individual and to the community. What's really fascinating, and these are the data I'm still trying to make sense of, is that when people are asked, do you have a strong preference or a slight preference or no preference of which vaccine you get? What's to me fascinating is that more than half of people say they have some preference to which vaccine they want. And initially, when the Johnson & Johnson vaccine came online, there was concerns it would be seen as a second-class vaccine, and therefore there would be greater hesitancy, or that the mRNAs would be considered the better or the higher class vaccines. They're more expensive. They're slightly more efficacious depending on the way that you measure severity of event. And so people have a strong opinion. What's fascinating, though, is when you break it apart, the preference people have is fairly equally distributed across all three vaccines. And in fact, the Johnson & Johnson is showing greater preference. In fact, when you look at people who have said that they want to wait and see how vaccines are working, a larger share of the hesitant group, that wait and see group, has said they would definitely get a Johnson & Johnson vaccine before they would get the other two. 1 in 6 people who in that wait and see group said they would definitely get a Johnson & Johnson, compared to 1 in 10 about Pfizer or Moderna. And that's really interesting in terms of how people are understanding the technology. how they're understanding the importance of a one-shot regimen over a two-shot regimen, and how they're weighing information about themselves, their families, their goals, their communities, and their trust in the vaccine science and systems. As we think about how to move this conversation forward, I wanted to think about some of the pieces in this. So what we know is that people are making decisions as they're situated in their daily lives. And these decisions are going to be tied to their goals, to their ability to return to school or education, their ability to earn wages or to travel, or to protect the people they care about around them. That they're making these decisions and they are weighing all of this information with a great deal of uncertainty. And what's informative, though, is that amongst those who are not yet vaccinated and say they do not want it as soon as possible, we know that both policy and accessibility matter to our story. So when asked about, and this is just the people who said they do not want it, that they're not in a hurry to get it or they do not want it, that knowing about access to travel, to knowing that you wouldn't have to wear a mask, or having access to it through regular medical care that was routine, seems to improve the chances people are going to want a vaccine. So we know that there's going to be a policy context to all of these conversations, and that thinking about accessibility to public spaces and experiences, and also the accessibility of the vaccine itself, are going to matter moving forward. In the coming months, we're going to face a new interesting challenge. We have been, for the last several months, watching a world of scarcity and shortage of vaccine, and we've had prioritization groups. Colorado has moved through prioritization groups much faster than many other states, but we know that there are still frustrations with long lines, with access to vaccine, with the ability to get it on demand. And what we can anticipate this summer, the estimations in Colorado are late May. Nationwide, it's closer to June, mid or June or so, is that there will be a tipping point where everybody who has expressed an interest in the vaccine will have gotten it. And then we have to face the challenges of thinking about, for the people who still want to wait and see, or the people who say they do not want it, how do we begin to have more complex conversations that are two directional, that allow people to ask questions and get good answers, to have conversations about what these things mean and how they can make decisions that accomplish their goals. We're going to have to combat some myths. And so this question of harming of fertility is ubiquitous and hard to kill. Here's a screenshot of the original article or story that Dr. Goodrich mentioned in December that drove some of these concerns about the different kinds of proteins. We have to have conversations about the fact that although there's no way to predict who will be most decimated by COVID infection, the statistics that people keep floating about how most people recover, the ubiquitous meme that 98.5% of people recover, why do we need vaccines, is really important for us to think through how we communicate about that. The perception that it's not necessarily a very serious disease is particularly challenging as we think about young people's interest in vaccines and what the risks and benefits they perceive are. And I keep saying perceive, because although risk is a mathematical calculation, most people don't do risk assessment in their daily lives mathematically, which is why we know Americans fear things like shark attacks and lightning strikes more than car accidents, despite the statistical implausibility of those. But risk is emotional, it's intuitive, it's value laden, and it's subjective. And that's really important for us to connect to people on those levels. We also have to acknowledge that there are some uncertainties, that when we have a virus we've only known about for a year and a vaccine we've only had for 4 months, we still don't know a lot of things. And because we don't know everything, it does not mean we don't know anything, but we have to have honest conversations about what we know and don't know. And when we say follow the science, we have to acknowledge that science changes as we learn new things. And that's been true for all vaccines over time, whether it's the HPV vaccine, where we learned that if you start the series as a young person, you don't need all 3 doses, whether it's the hard-fought lesson of measles, where I'm from a generation that didn't receive boosters, and as a result, there was large measles outbreaks in young adults when I was in college. Thinking about how do we learn and improve practices is an ongoing process, and that is equally true for COVID vaccines. We have to think through what these long-term outcomes of infection mean. So even though people quote recover, we don't yet know what recovery means. We don't know the long-term outcomes for circulatory, vascular, and cardiac health. We don't know what it means when children who are asymptomatic present with multi-system inflammation syndromes. We need to understand more about these. We don't know duration of protection. We don't know how perfectly transmissibility is prevented by vaccines. And although we don't yet know that duration of protection, it seems really clear that we do know that this is likely a virus that will require boosters, and maybe not as often as seasonal flu vaccines, but this may not be a sterilizing vaccine in the way a measles vaccine is, where you get it once or twice in your lifetime and you're done. And that's how we're all used to thinking of vaccines, because most of us have not encountered vaccine preventable diseases in our lifetime. And so we have to acknowledge that there's an uncertainty about this booster question, and that doesn't mean the vaccine is not valuable. And then finally, I've been thinking about this tweet all week, so I thought I would give you a screenshot of it, which is one of the most serious side effects of the vaccine is realizing that free healthcare is amazing. And as we think through the future of how we're going to deliver boosters or how we're going to continue to have accessibility for vaccines, we're going to have some conversations about, will this become a profitable vaccine despite the fact that citizens paid for this vaccine through federal monies and infusions of investments? The federal government has ensured access to the vaccine. Is that still true? We've tried to create as many open doors where you can access vaccine through a variety of health providers, which has actually been a kind of amazing. Are we really going to pull back from that and turn this back over to those large institutions that only serve certain people very well? And these are questions we should continue to grapple with and dialogue around that remain unresolvable at the moment, but they are opportunities for reimagining how we do community health and work towards those questions of protecting everyone, even the most vulnerable among us. And so I think what I'm going to say is, at the last point, is that despite all of my doom and gloom about hesitancy and thinking about these opportunities, it's worth just highlighting real quick that when you ask people, how happy are you? How satisfied are you with the way the COVID vaccine process is going? What you will see is that the majority of Americans across all political spectrums and all age groups are really satisfied. And that underscores that last point, that we have made this accessible, we have rolled this out very quickly, and we have made it a relatively hassle-free process. And that's an important lesson to learn. When we started the COVID pandemic, there was all these memes in circulation that really pointed to the fact that a vaccine was our solution, that it was a magic bullet out of this, and really highlighting, and with some snarkiness to people who oppose childhood vaccines, that this is exactly what a world without vaccines look like. And it was cynical or optimistic, depending on your perspective, but it really ignores the way that vaccine decisions are complex, they're situated, they draw on our existing systems of inequality and magnify them, and they require much better conversations than simply dismissing people's concerns. And I'm going to stop there, and we can have a conversation. Thank you so much.
Thank you, Dr. Reich. I just had a two-parter for you. I saw a poll this morning that showed a majority, albeit a slim majority, of Americans support so-called vaccine passports. At the same time, I've heard you in interviews highlight the need to not vilify those opposed to vaccinations, and in order to promote a healthy dialogue. How do we reconcile these two interests?
Yeah, so I started studying vaccines more than a decade ago, thinking about childhood vaccines and then the way people make decisions that are situated in their lives. And what I've come to believe is that I can think of no circumstance where calling people stupid, ignorant, or yelling at them has ever persuaded them to change their decisions or behaviors. And so that by itself is an opportunity, despite the frustration that people feel around the pandemic and the ways they can't understand vaccine refusal, there's opportunities to hear where people are coming from and what their concerns are. When it comes to this broader question of passports, we have a situation where the federal government has announced that they will not be overseeing this. I heard Governor Polis interviewed this morning saying he did not think the state would be creating any requirements. And so this has really been turned over to the private sector. What concerns me about that is that the private sector is never better on things like employment protection, pregnancy discrimination, personal and confidential health information. The private sector is never good on religious liberty or freedoms for religious minorities. So when we think about how are we going to do this, the fact that this has been handed over to the private sector where individual bars and restaurants are coming up with their own public health policy is concerning. And it's a missed opportunity for us to have better conversations and to make sure that we are always advocating for those who are most vulnerable among us. And that's the space where I think our conversations have to go.
Thank you for that. I just also want to remind everybody to feel free to submit your questions. There's some good questions I see rolling in here now. We'll get to them towards the end of the presentation. I'm going to transition here from Dr. Reich to another doctor. Our final panelist here has been on the front line of vaccination politics as a primary care provider and as a Colorado General Assembly member. Dr. Irene Aguilar worked as a physician at Denver Health for 23 years and served as a member of the Colorado Senate from 2011 through 2018. It was a sad day when she left. She recently retired from her position directing the City of Denver's Neighborhood Equity and Stabilization Program. And right now she chairs the Immunize Colorado's Board of Directors and serves on the Colorado Vaccine Equity Task Force. Dr. Aguilar, thank you for joining us.
Thank you so much, Jake, for having me. And Jake, did you want to prompt me with a question, or you want me just to go loose and wild?
Oh, I can prompt you. So as mentioned, you've been both a senator and a physician, so you have a unique perspective on vaccine politics. Could you share your thoughts on how policymakers should address vaccine hesitancy? What policies, for example, can we adopt to improve vaccination rates?
Mm-hmm. So thank you for that question, Jake. I think the first thing I want to say is that one of the great unfortunate things that's happened in the last 4 to 5 years of politics is that science has become political. And there are people who quote unquote believe in science and don't believe in science. And that is really unfortunate because the evidence of the value of science and vaccination has existed in our history for the last 50 to 100 years. And unfortunately, or fortunately, people don't recognize it because we don't see people with polio and physical malformations. We don't often see people with measles and outbreaks. And so I think as policymakers, and we need to figure out how do we try and change the conversation from one about politics to one about science, and how do we get people to really understand the science behind it. I think the one of the things that we have tried to do in the legislature is actually to recognize that people who choose to vaccinate also have rights, and they have the right to ensure that their children and their families are protected. So sort of turn the argument a little bit. You know, you may say it's my right not to be vaccinated, but I think parents, particularly those of children who are medically fragile, also want to have the right to know when their child can be in a safe environment and that they're not putting their child at risk. And so I think that's one take to move on to things. The second is to, at this point in time, at the very least, to reject legislation and policy that's being brought forward. And there actually is one in Colorado right now that are setting out mandates against requiring vaccinations. And so for the longest time, the state has had requirements for vaccinations for entry into school. And so because of that, there are legislators who unfortunately are Republican who are trying to introduce legislation even this year that say that facilities, jobs can't require vaccination as a condition of employment or participation. And so unfortunately, we need to go a little bit on the defense. From the increasing vaccination perspective, I think it's one of the beautiful things about the coronavirus vaccine has been that it's really been brought into the community. And I think that as we see the state of Colorado be more successful in that, we see the disparities between our BIPOC populations and our white populations narrow. One of the wonderful things that the Colorado Vaccine Equity Task Force has is the pleasure, along with Immunize Colorado, to administer some funds that are giving grants to small local organizations that have contacts with diverse populations to ensure that those populations can get their vaccines in places where they feel safe. I thought Dr. Wright's statement about how the systems that normally are isolating or exclusionary of people who are at higher risk can continue to do that with the vaccine without any intention. It's just the historic nature of it. And so it's been great seeing the opposite happen, where organizations that are in the community, serving our communities who are vulnerable, are proactively taking efforts to bring the vaccine directly to them. And I will stop there because I know we have some other questions you want to address during this time.
Yeah, I was thinking about the tweet that was shared by Dr. Reich that said that, one side effect of the vaccine is that people find out that free healthcare is awesome. And then also, so I received my vaccine through the Indian Health Service, and I saw with both my tribe and in other places like Alaska, where tribes were actually way out ahead of the general population in terms of the speed of distribution. A big reason for that is because distribution was more centralized and coordinated, and kind of opened your eyes to what could be if our healthcare system is different. My question for you is, do you think that there is going to be any sort of political shift in attitude about healthcare based on the experience that people are having during the pandemic and its recovery?
So two parts about it. I think one thing that we will see is the recognition that those hard to reach populations aren't that hard to reach if you work with the population itself. Part of the mission of the Vaccine Equity Task Force is that this group of diverse people are out there sort of preaching the gospel of vaccination. We need people to hear from people who are like them and who they trust, that this is something safe and that can be done. And I think the success of that effort will lead to changes in models moving forward, just like the success of the community effort will lead to not expecting people to come to the health center anymore, but to find more ways to bring healthcare to them in their natural environments. And so I think those two things are natural outcomes of what we've been dealing with now. One of the great things about COVID is vaccine is that you don't have to show identification. You certainly don't have to show documentation that you're a citizen. You don't have to have insurance. It's a by right entitlement. And I think there are lots of people, even not just people who are here without documentation, but just lots of people who don't like to share their private information. And by getting rid of that barrier, you get access to more people than you do without. And so I'd hope that we could find a way to use these lessons to make healthcare more accessible for people who are loath to access our big systems right now.
Thank you, Dr. Aguilar. We are going to shift now to questions for the panel from audience participants. I've got the first one here from Dirk Bauma. I hope I'm pronouncing your name correctly. He says, this morning I took a PBS poll online that instantly gave the result of persons who took the survey, about 114,000 people at the time I took it. The survey result indicated 25% of those taking the survey have no intention of getting the vaccine. Given adverse messaging among many subpopulations and the data presented, will herd immunity be possible at all? What do the scientific and engineering communities need to do to affect change in the messaging?
I could take a stab at that just initially. First of all, I think the more people that are vaccinated, the better in terms of being able to achieve herd immunity. But there is a sort of threshold cutoff that you want to achieve. Whether that's 70% or 80%, I think is still somewhat debatable. But as we see those percentages increase, you're going to get closer. And I think some of the data is indicating that you are getting closer. We are getting closer to being able to achieve that. Also remember that this factors in people who are infected. Because there is an immunity that's attained when you're exposed to the disease. So it'll be unfortunate, but they do contribute. People who become infected do contribute to the herd immunity by virtue of being immunized, essentially, and being able to prevent exposure to others. We would hope that people don't have to go through that, and that's why we encourage the vaccination programs. I think that what do we have to do as scientists and engineers? Well, I think we have to be willing to dialogue with people. One of the most powerful points I think you can raise in any discussion that I've had throughout my professional career is asking the question or making the statement, help me understand. Help me understand what the hesitancy is, help me understand what the issues are, the concerns about vaccination, so that we can talk about them, so that we can research these questions together and hopefully arrive at answers. I like Dr. Reich's comment about, calling people stupid or ignorant doesn't solve a problem. It just creates more. We have to be willing to dialogue. We have to be willing to understand what the concerns are. The people who get vaccinated love their families, love their children. The people who don't love their families, love their children. So do the people who make vaccines. And so we need to come together in a way to understand what the issues are and be willing to dialogue and address them. Sessions like this and others where we can have these kinds of conversations are incredibly important.
And I would just add on that, we talk about herd immunity, and unfortunately, experts are talking about herd immunity before there was evidence of herd immunity from this vaccine. And that's worth noting that not all vaccines work the same way. We have vaccines that provide no herd immunity, but they provide huge individual benefit. And we have other vaccines that mostly provide benefits to others and less to this individual. And we have a continuum of what vaccines do socially, and they're all a little bit different, and they're all important in their own ways. What's challenging with this is that the outcome measures of the clinical trials didn't include infection, asymptomatic transmission. It didn't include measures of that. The measures that were chosen were life-saving. And that was important, but it was only one kind of answer. And so some of people's hesitancy too is not knowing yet whether this does prevent transmission, whether this does eliminate the need for masks. How does this protect your grandparents if that's your priority? And as we are learning, and it's clear that now there's more transmissibility prevention than initially imagined, as people are learning more, they're recalibrating some of those decisions. The most important thing I think Colorado is doing right is that we have prioritized equity in our allocations every week. We've prioritized pop-up clinics and community partnerships in ways that's fairly innovative. And the work that the coalition, Immunize Colorado, is doing around some of these issues is also to create opportunities that Dr. Aguilar highlighted about two-way conversations. We don't live in a culture anymore. We don't live in the polio era anymore, where scientists tell us what to do and we follow instructions. And some of that's been really good because it's allowed us to question medical practices that have been racist and discriminatory, that have diminished people's experience of their bodies and their lived perceptions and experiences. And it's also been really challenging in terms of thinking about what does it mean to democratize information. And both are really important. So we have to keep creating spaces for those conversations.
Thank you. We just have one more question from the audience here, but I had one follow-up question with respect to herd immunity. I don't know if Dr. Goodrich or Aguilar or anybody can answer this question. You mentioned earlier that we can expect to retain immunity for at least 6 months after we get vaccinated. What about if you've been previously infected but don't have the vaccine? How long can you expect to have some level of immunity?
I think we're still finding out the answer to that as well, which is why the recommendation is still that if you are an individual who contracted the disease, that you still be vaccinated. And so we're still determining, because again, as was pointed out, it's only been in the last several months that we've had access to this. But as we continue to track, I say it's at least 6 months because that's where we have data. It's not likely to drop off a cliff at that point. We will continue to accumulate information and extend that out. I don't think that we can answer it definitively today to say how long someone would be protected either from natural infection or from immunization through vaccines.
Thank you. All right, so we have our last question here from Nicole Carloni. And the question is, how does the shift in attitude and or willingness to get vaccinated relates to the spike in case numbers we saw in the fall and winter? You mentioned that there was a change when the vaccine became tied to politics, but is there any evidence that hesitancy increased when cases decreased, i.e., I don't really need the vaccine because we can stop the spread without it, and decreased when cases started rising dramatically around the holidays. You all track that there?
I'll answer this sort of a 5,000 foot overview. You know, that when people make decisions about vaccines, they're weighing their perceptions of risks and benefits, and is this vaccine personally beneficial, and what do they perceive the risks are, and how do they make these decisions? And as Dr. Aguilar noted, you know, this is an individual process where people talk about their own interests, their own rights, their own values, their own perceptions of risk. And that's not surprising because we've individualized all of healthcare. We ask people to take personal responsibility for everything in their life, and we don't identify the ways that there's community obligations and community privileges, and that we are all tied together. And infectious disease makes that clearer than anything else, that we are not alone in our decision making. Our risk does not stay with us at the end of the day. And so in thinking about those perceptions, yeah, we see that with childhood vaccines. Clearly, you know, parents told me frequently that, you know, polio hasn't been in the US since 1979. So why are we vaccinating kids against polio? Without recognizing that this is part of a global campaign, that this is part of managing communities long-term, right? That we are all participating in something bigger than ourselves. And we haven't had great opportunities for dialogue about that. And unsurprisingly, because we ask people instead to download an app to count their steps or their calories, right? We continue to personalize and individualize responsibility. And it gets to be really hard then to say, this is the place where you have to step forward for other people to make sure people's children are protected, to make sure people who are vulnerable in our community are protected. And so I think that, you know, part of that, as people are weighing information, yes, hesitancy goes up and down based on perceptions of necessity. But the bigger picture, I think, is this other question, which is that it's not just the risk in your house, on your block of getting the disease, but who do you encounter, who do you see, and how can you be part of this broader solution? And I think that's an opportunity we have moving forward too.
Well, I want to thank you all. I also want to thank our sponsors, Science is Us, as well as Chronic Care Collaborative, the Colorado Vaccine Equity Task Force. This has been really informative. I'm glad you all could join us, and have a great weekend.